So as of now, we are recording the session, so please don't include any confidential health information during the session if you're discussing any cases. If you do wish to receive any CME or CEU or attendance certificates, you do need to announce your name. You can do that through the chat box after our roll call if you need to. So that gives you an opportunity not to have to interrupt or anything like that. That way you can get your CME certificate, and we do those once a month, the second week of the month. Your computer video and audio are on by default, so this is how you mute them. Find the stop video or start video to toggle those two, and to mute and unmute, same kind of thing there. If you do need to join by telephone, you might need to grab the arrow next to the mic and select audio options, then join by phone. It gives you detailed instructions on how to join and how it links up with your video as well. Our disclosure and accreditation statements are on screen now. We're required to have those on screen to give out CMEs. And Molina Healthcare and Blue Cross Blue Shield New Mexico has partnered with us to reimburse you for doing case consultations with us. So if you have an actual case and you can bring it to our AHI New Mexico session, we can bring our group of experts here and be able to help you with that case and give you written feedback as well as verbal feedback. So it's not like rounds, so you don't need to be nervous about it. Not that I've experienced that, but I hear it's not the funnest thing. So please, at this point, just contact me for more information about that. Or actually, the contact information for Molina and Blue Cross has changed, as well as the codes. So we're kind of on a holding pattern for that, but the agreement is still in place, so you will be reimbursed for those. And it's also a big part of AHI New Mexico. If you want the certificate, which Carol will talk about a little more in detail in a minute, then you do need to provide one case consultation for AHI. Now, if you don't see patients, you can always bring a fake case, and we can help you out with that.
Yes.
So a mock case would be a nice way to say that. All right, so if you do wish to receive CME or CEU or an attendance certificate, please tell us your name if you're out there on a mic. Go ahead and let us know that you're there. And I'm promoting a couple of people so they can use their video and audio. One moment. And as I stated before, but before a couple of you were there or had joined us, you can use the chat box as well. And you should see that flashing at this point.
Hi, it's Stephanie Nevares-Fernandez. I'm having connection problems. Good morning, everybody.
Good morning.
Good morning. Sounds like you connected okay, though. Okay, well, while we're waiting for others to chat in, oh, Diane Lowe is also an RN, has chatted in as well. So we can go ahead and go around the room and introduce ourselves.
Good morning, I'm Carol Conley. I'm a social worker by training, and I run some quality improvement initiatives here at Envision, New Mexico.
Hi everyone, my name is Emma Clapp. I'm an MSW student and an intern here at Envision, New Mexico.
Good morning, I'm Lauren Thorpe. I'm a pediatric resident at UNM.
Yeah, good morning, I'm Mike Weiner. I'm a fourth-year medical student at UNM.
Good morning, I'm Kylie Boone. I'm a medical resident at UNM.
Hello, my name is Maya Trujillo. I'm a quality improvement specialist here at Envision.
Hi everyone, my name is Felina E. I'm one of the pediatric residents at UNM.
And we can go ahead and turn it over to Carol Conley, our facilitator.
Well, thank you, everyone, and welcome to Studio Envision. This is the second session in our Adolescent Health Initiative New Mexico. It is our goal to bring you up-to-date information and resources related to the care of teenagers. This is a certificate program, and we really invite you to sign up for the certificate. And if you choose to receive the certificate, You must attend 10 of the weekly sessions per series. A minimum of 6 of those need to be live. The rest you can access through our Moodle platform. You can contact either myself, Carol Conley, Maya Trujillo, or Michelle Widener about how to access the Moodle and get your certificate paperwork. We would ask you to complete a pre and post participation survey and present one adolescent patient case for consultation. And as Kevin said, if you don't have access anymore directly to adolescents, we can help you write that case study. And you have a few more weeks to sign up for the certificate. So I really want to ask you to take advantage of this amazing and free offer. Or that for a sales pitch. Okay, so now I'm very pleased to introduce our speaker today for the Adolescent Health Series, Dr. Jacqueline Fridge. Dr. Fridge is an associate professor. She's the division chief of pediatric gastroenterology at the University of New Mexico Health Science Center. She has a strong background in clinical pediatric gastroenterology, hepatology, and nutrition, and has had the opportunity to learn and work at institutions with diverse and challenging patient populations across 2 continents. Thinking about the health challenges of the children in New Mexico and the opportunities to make a difference, she has spearheaded the development of a pediatric hepatitis C initiative. She started over a year ago. Maya and I are delighted to be able to work with her on the project, and we're so happy to have you here. So without further ado, Dr. Fridge.
Thank you, Carol. Good morning, everyone.
Good
morning. Well, it is great to be able to talk to you about hepatitis C in children, and I could not think of a more timely topic because, as you know, lots of exciting things are happening in hepatitis C in the adult and the pediatric world. And so I wanted to kind of get you thinking about Hep C with these prompts. Do you have children with hepatitis C in your practice? And I think, I hope by the end you're going to reflect that even if you don't know you do, maybe you do. And we're going to spend some time really thinking about who should we be screening for Hep C. And something that I'm very interested to discuss with you, will get you thinking about, is how do you feel about treating hepatitis C in your practice now that the direct acting agents are approved for children? So let's just do a little bit of background. I'm going to talk about hepatitis C, and I'm going to talk about hepatitis C in adults. I'm going to try and kind of whiz through it just as a foundation, and then we'll focus more on talking about children. So as you know, it's an RNA virus. So you remember when you order those PCR tests for hepatitis B, it's a PCR, a DNA PCR, but for Hep C, it's an RNA PCR. And the virus is in the same family as West Nile, another disease we're familiar with here, yellow fever, dengue fever. There are 6 genotypes. 1, 2, and 3 are the most prevalent, and 1 most prevalent in the US. However, there are different populations, particularly the incarcerated population, even here in New Mexico, where genotype 3 is much more prevalent. The main site of replication is in the liver, but also in the peripheral mononuclear cells, the white cells. So you will see that that has some relevance when we get to talk a little bit more about vertical transmission. This is one of those amazing viruses that has a massive replication cycle and produces millions and billions of viral genomes. The genome is only 9 proteins, and it's very error prone, so there are many variant viruses, which is of interest, again, with vertical transmission. Babies can have quite different genomes than moms. Why do we care about Hep C? Well, for adults with hepatitis C, they have a 3 times higher mortality than their peers. They die 22 years younger than their peers of cirrhosis, liver failure, and kidney failure. And so it is a very important cause of morbidity and mortality. Prevalence, as we know, is pretty massive. And worldwide, maybe 5 million infected children. And prevalence varies widely around the world, with Egypt being one of the highest. In the US, it's estimated there are about 4 million adults living with Hep C, and it's a male predominance, and as you know, there's a particular focus on baby boomers. When we compare different racial and ethnic groups, non-Hispanic blacks are 2 times more likely, and Native Americans 3 times more likely to be diagnosed with chronic Hep C as compared to non-Hispanic whites. When we think about children, the prevalence varies by age group, with the preschool children having the lowest prevalence. As we get into school-age children, the prevalence increases, and the highest prevalence, not surprisingly, in our misadventurous youth, those young adults that are most commonly obtaining it through IV drug use. So in the US, close to 50,000 infected children is the estimate, but really there's very, very little data, and that applies to New Mexico as well. So we know that New Mexico is one of the highest prevalence states. It's right up there in probably the top 3 or 4 states in the US for prevalence of chronic Hep C in adults. And so it is entirely predictable that that high prevalence would be mirrored in the children of this state. And so based on the 2016 census data, I would guess that we've got close to 1,000 chronically infected children in the state. And just to put that in perspective, we only have about 20 or 30 children that we follow here at UNM. So where are the rest of those kids? And my guess is that they're undiagnosed. The geographic distribution you can see here, I don't think it will be a surprise to you. This is the adult prevalence, with the darker colors being the highest prevalence counties, and the white ones having no data. So the risk factors in adults are pretty well known: IV drug use, hemodialysis, sexual intercourse with an IV drug user, blood transfusion prior to 1992, adults who've obtained it vertically, incarceration is a big one, unregulated tattoos and piercings, a higher risk if you have a co-infection with HIV or hepatitis B, and solid organ donor recipients. So we're talking about patients we should be thinking about screening, but what about the different tests? We have a number of different tests available. So let's talk about what those tests are, and then we can talk about when to use which test. So the one that we're probably most familiar with is the antibody test, and it's an IgG antibody, and it's pretty sensitive and specific, and it's considered a screening test, so it doesn't prove you have chronic Hep C. As you know, it's not valid under 18 months of age because those babies still carry maternal antibody that came across the placenta. You cannot distinguish between past and current infection, and when you have a new infection, it can take as long as 2 months for you to seroconvert. Now, when you think about doing those hepatitis panels, we think about hepatitis A, how we commonly get the IgM, but for Hep C, the IgM is not useful and is not generally tested, only the IgG. So we also I already referenced the PCR test. In this day and age, we're generally doing the quantitative test, not such a role for a qualitative test. It can be positive within a couple of weeks of acute infection, so before your antibody will seroconvert. This is a very important test, and the one that we use a lot when we're talking about treatment and cure, which we define as sustained virologic response, meaning that we can't find the virus on a quantitative test or a qualitative test. There are some newer tests available, including the point-of-care testing, and I think that there's been some discussion about rolling this out in high schools in Albuquerque. For some places already testing HIV. So this may be added on for children that self-identify as having risk factors. So who do we test, and what tests do we use? So these are adult guidelines, and I'm just going to go through them because it highlights some of the pitfalls of testing. And what test you use and how you interpret the results is going to depend a little bit on your level of concern. So the U.S. Preventive Services Task Force recommends screening all adults who are baby boomers, so born between 45 and 65, with the antibody screen. After that, you're going to be testing people based on risk factors. And so let's go to the chart here and the top half of the chart. So these are people where we don't think they've had an acute exposure in the last 12 weeks and they don't have any signs or symptoms. So they're people that we consider in a risk category but not high risk. So we're going to start off with the anti-HCV antibody. And if that's negative, if they're low risk, we may consider that we're done. If the antibody is positive, then we're going to go on to confirm if they have a current active infection by checking the RNA PCR. And if that's positive, then we've confirmed they have chronic hep C. If the antibody is positive but the RNA is negative, then we have a couple of options. Either this could be a false positive, but we talked before that that sensitivity and specificity is pretty high, in the high 90%. Or it could be that they've had a past infection that they cleared, a past infection that's been treated, or they could have an acute infection. And the reason I include acute infection here is that the virus levels can fluctuate quite a lot. So you could just be testing them at a time when the virus levels are somewhat low and not picking up. So if you're pretty suspicious that they do have hep C, it's recommended to check labs again within the next 6 months. So going to the bottom half of the chart there, now we're going to a group that have had a known exposure in the last 12 weeks, or they have signs or symptoms. You're pretty convinced they could have hep C. In this patient population, you may want to go straight to testing both the antibody and the RNA just to speed up your results. So if they're antibody positive, you're going to check the RNA, and if that's positive, you confirm the chronic infection. If they're antibody positive and RNA negative, like I said before, we could be in that situation where it's an acute infection, virus levels are fluctuating, or it could be a past infection. If they're antibody negative and RNA positive, then it's acute infection. They haven't seroconverted yet. If they're antibody negative and RNA negative, as we said before, if you're suspicious, you may want to repeat the testing within 6 months. So if there has been an exposure in the last 6 months, if they're immune compromised or reinfected after treating, clearing an infection, then you may just want to go straight to the RNA and not do the antibody testing. Screening based on risk factors increases sensitivity, as you can see from the statistics there. Antibody, the RNA PCR is going to be positive within 2 weeks of acute infection. And as we said before, if you're antibody positive, RNA negative, you should probably repeat within 4 to 6 months. So that's just some algorithms for testing. And let me know if you need any clarification on that. So knowing the genotype will also help for treatment, and we'll talk about that a little bit more. So in adults, say we've established that they have hep C, what do we do? Well, we want to establish the morbidity associated with that, and we want to evaluate the liver. Generally speaking, liver biopsy is not done routinely. It would be the exception. And we're using non-invasive methods like elastography or some of these panels of serum markers of fibrosis. This is actually less important now than it was even a few months ago, because the insurance companies have been changing their criteria for treatment. And in the past, you had to show significant fibrosis to qualify. Now, fortunately, those criteria have been loosened. So let's just quickly review the natural history in adults. About half of adults are symptomatic when they get an acute infection, and about 75% develop a chronic infection, meaning they're still positive after 6 months. Chronic infection, many adults don't know when they are infected and have been infected for years before diagnosis. And many adults have a fairly benign course with just some arthralgias and myalgias and fatigue. And it's interesting talking to my colleagues who work with the adult population. I think that fatigue is something that people don't really notice until they're treated. And then they really appreciate this huge increase in energy and desire to participate in activities. Cirrhosis occurs in 10 to 20 people after 2 to 3 decades. It's nonlinear in progression, and about 20% of people per year with cirrhosis will become decompensated, and at that point they have a 50% 5-year mortality, so that's pretty significant. And hepatitis C is the #1 reason for liver transplant in adults in the US. So risk of progression is lower if you're younger, female or white. Higher risk if you are a heavy alcohol user, you've had a longer duration of infection. You have metabolic syndrome, again, very interesting experiences in the adult world with patients who have metabolic syndrome and type 2 diabetes, where the diabetes resolves on clearing the hep C infection. So more risk of progression if you have HIV, hepatitis B co-infection, Latin ethnicity, and also some data on daily cannabis use being associated with heavier risk of progression and less effective treatment. So these are some of the comorbidities that are seen in adults, and I'm just going to skip right on because we don't see these in kids, very rarely. And this chart just talks about goals of treatment, and really what I'd like to emphasize here is, just like with polio and measles, this concept that we want to get the virus out of the community. We want to treat at all levels and stop the spread of the virus. And this has led to quite a sea change in philosophy of treatment. So for adults in the past, you had to be clean and sober before you would be treated. Now there are studies where they're treating active IV drug users. And the HERO study is a large multi-center study that UNM is participating in. Our PI is Dr. Kimberly Page, and it's a super fun project. They are treating active IV drug users who have hepatitis C using a comparison of a variety of directly observed and navigation tools to ensure adherence. And one of the tools is that the study participants have to video themselves on their phone every day taking their meds and upload it to an app, and then someone gets to watch it. So lots of innovative things going on, but like I say, a real sea change in the way we think about who are we going to treat, from only treating people that are clean and sober to treating everyone to try and decrease this virus in the population. So let's talk about children. Phew, we got there. Vertical transmission. So a lot of interest in vertical transmission, but actually the transmission rate is pretty low. And the vertical transmission rate does obviously correlate with the prevalence of chronic hep C in pregnant women. So here we are in New Mexico, it's going to be high compared to other states. So the prevalence is somewhere up to nearly 2%, which mirrors the prevalence in the general community. The overall risk of transmission, of vertical transmission of hepatitis C, is about 5%, but there are some other risk factors that play in. So some studies that look at this, and you'll see this quite a lot in the Hep C research, they lump any positive Hep C test together. So they don't differentiate between if it's serology or RNA testing. So if you're just positive on antibody tests, but no one knows your RNA status, then the risk of transmission is obviously lower. If you know someone is positive, then your risk of transmission is closer to that 5%. If you have multiple positive RNAs tested during pregnancy or right around the time of delivery, your risk of transmission goes up. It is much higher if you're co-infected with HIV, and it's also much higher if you have a high viral load, and that's been shown in quite a few studies. Oops. We don't really know when transmission occurs during pregnancy, and all genotypes get transferred. There is some suggestion that HLA typing, similarity or dissimilarity, may impact whether the HCV is passed on. And they're estimated to be about 7,500 new vertical transmissions per year in the US. And it has also been shown to be transmitted through sperm. So what are some of these risk factors? Maternal risk factors, we talked about co-infection with HIV and high maternal load. Prolonged rupture of membranes has been shown to increase the risk in some studies. No reduction in risk with a C-section, some concern about large vaginal tears. Maternal HLA, some types are protective. There's no association with maternal age parity, cigarette use, or alcohol use. Generally speaking, breastfeeding is okay unless the moms have cracked nipples or unless the moms have a postpartum flare of their hepatitis. Infant risk factors, possibly an increased risk with fetal scalp vein monitoring, fetal anoxia, again, protective HLA types in the infant, and possibly a slightly higher increase transmission in females versus males. Just to put it in perspective, and I apologize, the orders of magnitude aren't equal in this study, but this is transmission of torch infections, and it just shows you that, for example, transmission of toxoplasmosis is much more common than transmission of Hep C. So what about screening pregnant women? This is somewhat controversial. There are studies both ways. Generally speaking, people feel that it's not cost effective to screen all pregnant women, but certainly in high risk populations that may change. Screening transaminases is not useful because of the immune effects of pregnancy, and they often normalize. The American College of Obstetrics and Gynecology recommends screening pregnant women with risk factors. There was a 10-year study in the UK where they screened 35,000 women, and they found that they had 136 women who were antibody positive. Of those, 78, so about half of them, had active viremia, and of those, more than half of those were new diagnoses. They did not know they had Hep C. They had 3 vertical transmissions in this group, and 19 women were treated postpartum. This was in the era still of interferon and ribavirin. And in their algorithm, they found this screening to be cost effective. What's exciting and may change how we feel about screening pregnant women is the upcoming approval of sofosbuvir and ledipasvir for treatment during pregnancy, and that would, I think, really be a game changer. So there are some articles. This particular article talks about why we should be screening all pregnant women now that we have these new, much more potent, highly effective, and low side effect medications available. And the argument they make is that pregnant women with hepatitis C have worse maternal and fetal outcomes. So more gestational diabetes, preeclampsia, growth restriction, antepartum hemorrhage, preterm birth, gestational cholestasis, and that the physiologic state of later pregnancy may favor viral replication, and we know higher transmission if your viral load is higher. And for infants born to Hep C positive moms, they have worse outcomes independent of whether the moms are IV drug users, so they have low birth weight, higher incidence of ventilator assistance, NICU stay, and possibly congenital pneumonias. So how else do kids get hepatitis C? Well, unfortunately, probably the most common way overall is through IV drug use and needle sharing, possibly high-risk sexual activities. There is a small risk with household exposure and unregulated tattoo or body piercing. So whom should we test? And I've kind of, over the next 2 slides, I've smushed together a bunch of guidelines that I came across to give you a little bit more detail on who to think about screening. And I think this was available as a separate handout as well on the website. This one is pretty obvious. Adolescents who've injected drugs, even in the remote past, including those who've injected only once and don't consider themselves to be drug users. And the test you would want to use here is probably an antibody screen. Children and adolescents that have other conditions associated with a high prevalence of HCV, so that's going to be your patients with HIV, hepatitis B, or patients on hemodialysis. And you may want to get antibody and RNA, or just RNA, depending on how immune suppressed they are. They may not be able to mount that antibody positive IgG, so the RNA test is going to be a default. Obviously, you're going to want to test children born to HCV positive mothers, and we do the antibody screen after 18 months because of that maternal transmission. However, what we're finding anecdotally with some data from Nicole Yonke at Family Medicine from the Milagro Clinic is that the problem is that even when you know moms are Hep C positive, if you wait till 18 months to screen the children, many of them have been lost to follow-up. So you could certainly make a case for doing an RNA test earlier, and we'll talk about that a little bit more. Sexual partners of patients that have hepatitis C, we're going to want to do the antibody screen. Children with chronically elevated transaminases, you're going to want to do the antibody screen. Children who present with signs and symptoms of acute hepatitis, you're going to want to get that panel, which does the Hep A IgM, some of the hepatitis B serologies, and the Hep C antibody. But as we talked about before, you could be in that serologic window, so you may want to do an RNA if you really are concerned about Hep C. Children with an intrafamilial exposure, you may want to do the antibody test. Children and adolescents emigrating from a high prevalence country. And this reference, which is on the next page, is a really interesting article showing the prevalence of HCV in countries from each of these areas. And I picked the top 3 from each area. So for North Africa and Middle East, we're talking Egypt, we already talked about that, Iraq and Yemen. In the Central Sub-Saharan Africa, Burundi, the Democratic Republic of Congo, and Gabon. And then Central Asia and Eastern Europe, we do know about this high prevalence. We think about it particularly with international adoptions. Ukraine, Uzbekistan, Georgia, Russia, a higher prevalence of B and C. And I know that if you meet children that have been adopted from those countries, that's definitely something that we screen for. Any adolescent that has ever been incarcerated should be screened with an antibody test. Adolescents who've been to unregulated tattoo or body piercing settings should be screened. Needle stick exposure screened. And then Dr. Page, who I said before, is working with various populations with HIV and HCV, recommends that children with a newly diagnosed STD should be tested. And I apologize, I don't yet have references for this recommendation, but I think it's a great group of kids to think about. Any questions on that tool, screening tool?
I have a question.
Yes, certainly.
This is Stephanie Nevadas from the First Choice South Valley, and I do have some patients that are exposed with mom or like come from foster care. So my question is, if it's a child that's over 18 months and there's a presumed exposure like IV drug use or STD, should I wait 6 months to test for the antibody, or do I immediately do that and then follow up with an RNA test? Like, what's the timing of exposure to screening?
I think if you have a high concern and you're waiting till 18 months to do any testing, I think you could make a good case for doing both. The first test, doing the antibody and the RNA. We're going to talk about this a little bit more. You're going to want to repeat that RNA probably at around 2.
Okay.
And make sure that they're still positive.
Okay. Thank you.
You're welcome. So as we said, that RNA can be tested. It's not recommending testing it between 2. Some places say 3. So you'll see in the slides coming up 2 and 3 months are mentioned. If it's positive in early infancy, it should be rechecked in 6 months and then rechecked again probably after 2 to determine if they've cleared their infection or not. So what are criteria for diagnosis? Well, if you have a positive antibody in a child who's 18 months or older and you confirm it with an RNA test, then that child has Hep C. If you have a positive RNA PCR at any age over 3 months, like I said, some people say 2 months, you're going to want to repeat it. Infants definitely have a transient viremia in the immediate neonatal period that may persist for a couple of months. And so you're going to want to recheck that after 6 to 12 months to make sure that that PCR is still positive. How do you say they definitely don't have Hep C? So you're going to want to get 2 negative PCRs at least 2 to 3 months apart. And how do you confirm that they've definitely cleared it? You're going to want to get 2 negative PCRs at least 6 months apart. And this table taken from the NASPGHAN article that I referenced earlier just gives you, again, some of the terminology that's used, and that's there for your reference. So what is the natural history of children that get Hep C vertically? So the good news is that somewhere between 25 to 40% will clear it. So the question is, was it really a Hep C infection? Was it transient viremia? I don't know that really matters. Typically, they'll clear by the age of 2. So, like as I said, retesting at or after the 2nd birthday is recommended. There have been case reports of clearing as old as 7. And this contrasts with adults who typically only clear within the first 6 months. Greater clearance of genotype 3 and some other polymorphisms, and a positive association that if you have a high ALT, so perhaps if there's more immune activation, then you're more likely to clear the virus. If you're chronically infected after the age of 2, about half of people are going to be asymptomatic, and as I said before, they may have that intermittent viremia, quite fluctuating virus levels in the blood. If you have a chronic active infection, you're going to have abnormal transaminases, you may have some hepatomegaly, you'll have a persistent viremia, and a small, very small number will go on to develop some fibrosis. Hepatocellular carcinoma is possible, still very uncommon in the pediatric age group. 80% of children with chronic Hep C have, even with vertical transmission, so by the time they're 18, they've had it for a couple of decades almost, 80% will have no liver fibrosis. So that's good news in some ways. So what about children that get Hep C other ways, so mostly through IV drug use? Well, not surprisingly, their natural history is much more similar to adults. A much lower level of spontaneous clearance, probably close to 80% go on to develop chronic Hep C, and A small number can progress to cirrhosis in childhood. Risk factors for disease progression are obesity, treatment of childhood cancer, congenital anemia requiring chronic transfusion, co-infection with Hep B or HIV, homelessness, IV drug use, alcohol use, incarceration. And as I said before, that long list of comorbidities really doesn't apply. Some risk of developing some renal disease, concerns about CNS impairment, learning impairment, decreased quality of life, and this whole question about fatigue, which is very hard to quantify. So,
About 5 more.
oh, 5 more minutes.
Okay.
Just chime in if you have questions, because I apologize, I've got way too many slides. So we already talked about evaluation. You're going to do the PCR, the genotype transaminases. You're going to want to do the liver function tests. And here I torture my residents. Liver function tests are not your transaminases. Liver function tests are what your liver does. What does your liver do? It makes albumin. It conjugates bilirubin. It makes clotting factors. So these are the things you should be checking. You may want to check renal function. If they think if you think they've had a chronic infection, you may want to do some nutrition screening. Thyroid screening mainly relates to medications. And I would recommend a baseline abdominal ultrasound just to make sure there are no nodules or concerning areas. We may want to work up further liver disease. This is a list of some tests we may want to do, which I can talk about more if you have questions. As a PCP, you definitely want to think about immunizations. They need to have Hep A vaccination series. You need to check Hep B titers, and if they're Hep B surface antibody titers, if they're less than 10, to repeat the vaccination series. They should get an annual flu shot, monitor growth. If their liver function, we already talked about that, liver function is normal, then there's really no restriction on NSAIDs or Tylenol. They should avoid alcohol. Referring them to us here at UNM, we would love to see these kids. We understand they are often a challenging population. We would monitor those similar labs. Liver biopsy, like I say, is uncommon. We do screen for hepatocellular carcinoma with an ultrasound and alpha-fetoprotein every 6 to 12 months. So how do we prevent transmission? And I'm actually going to skip to the next slide because it, again, is from a NASPGAN article, and it talks about contraindications, things to avoid, and what tests to do. So household contacts, no contraindication for sharing food, drink, utensils, towels, but you should avoid sharing toothbrush, shaving equipment, anything that might be exposed to blood. Screening is routinely not recommended in this article, which is from 2012, but like I say, a lot of things are changing, and certainly I would consider screening household contacts. Non-household contacts, they do not need screening. You are not under any legal obligation to disclose that your child has Hep C if they attend school, sports camps, daycares, because these places should be using universal precautions anyway. No contraindication to casual contacts, but with sexual contacts, monogamous relationships are considered low risk. Unprotected, multiple partners, higher risk. And then we already talked about tattooing and body piercing. So when to treat? Well, this slide is basically one that you should screw up and throw away, because like I said, this is the old thinking, and the new thinking is radically changing each month. Things are changing and criteria are changing, and so at this point, especially in older children, we are saying treat if you can. And so unfortunately, treatment for children under 12 hasn't changed, so it's still pegylated interferon and ribavirin, which has a lot of side effects, is a long course of therapy, 48 weeks for genotype 1, and a low SVR, only 45% cure. So basically, any child under 12, Unless there is a compelling reason to treat, we say wait until they're 12 and they can take advantage of the newly approved medications. And these are some of the side effects and difficulties of that old regimen. So April this year, direct-acting agents were approved for children 12 to 17 years old or over 35 kilos. And what's been approved is Harvoni for genotypes 1, 4, 5, and 6, and Sovaldi with ribavirin for genotype 2 and 3. And these treatments have a sustained virologic response of 97% for genotype 1, 97%, and 96% in quote-unquote real-world experience. So these are fabulously effective medications. And the treatment is only 12 weeks for genotype 1, and under some algorithms, depending on virologic response, could be as short as 8 weeks. Harvoni and Sovaldi both do have black box warnings for hepatitis B reactivation. I'm using the brand names because these are the only medications that are approved. You cannot get them as generics yet. Ribavirin has a black box warning for hemolytic anemia and teratogenicity. And the screening for direct agent treatment is very minimal, just CBC, creatinine, GFR, hepatic panel after 4 weeks, and then monitoring of your PCR, your RNA PCR. If you're taking ribavirin, then that does have quite a lot more morbidity and side effects. You do need to do more monitoring for ribavirin. And there are a number of websites that have great guidelines. But beware, there's a lot out there that's out of date. So here at UNM, we have named our project Project HCV. And we are just very interested in where are these children? Are they not diagnosed or are they not referred? How can we find them? How can we reach out to them? We have established a registry so that we can just document some demographics and comorbidities. Currently, we're only scratching the surface of whether payers are going to cover treatment for children, and we feel like we may need this registry data to advocate with the state or payers to cover treatment by allowing us to present data on certain carve-outs of population. Perhaps teenage girls of childbearing age, should we not treat these girls before they're pregnant, for example. And so we look forward to partnering with you to learn more about Hep C in the children of New Mexico. So just going back to our questions, do you have children with Hep C in your practice? Probably. And who do you think you should be screening for Hep C? I hope I've expanded your thinking a little bit more on who to screen. And how do you feel about treating children yourself in your practice? We are working with Dr. Aurora and Carla Thornton to partner with Project ECHO, and are hoping to offer pediatric time through Project ECHO to partner with you in treating children if you want to do that. If not, then obviously referring them to us at UNM, and we would be very happy to take on that task. And I'd be happy to answer any questions.
I'm going to ask a question. Thank you very much, Dr. Chris.
Thank you.
There's a lot of great information in there.
Too much, probably.
Well, open up your brain. Get a brain dump early on Wednesday morning. So for a clarification, when the children come to you, they've probably already been diagnosed. Is that correct?
Correct. Although we do get a lot of children where there's been a concern for vertical exposure, and PCPs want us to take on the responsibility, especially if kids are in foster care, of doing the screening.
So when we think about adolescents and the opportunity for the point of care testing, do you have any special kind of strategies you use to talk with a teenager about why you want to test, or even to get to a place where you realize they have some risk factors? Because it can be tricky to talk to young people about, you know, their sexual activity, their drug use, trying to make the safe space. And last week we talked about an adolescent-friendly clinic and how you would make that safe space. But I'm wondering, just in your experience, how do you address that head on? Do you have any tips for a primary care provider that may want to screen those kids, and how do they say that out loud?
Right. I think that's a great question. I mean, I think talking about our experience with knowing other teens that have contracted Hep C through these kinds of activities.
Okay.
I think talking about how Hep C is associated with, you know, chronic fatigue and just not feeling well. And I think really the conversation has changed now that direct acting agents are available, and we believe we're going to be able to get them covered. You know, being able to talk about a disease that we can treat and is obviously a game changer.
Yes. It's hard to have those conversations. I mean, not everybody's comfortable. We do a lot of motivational interviewing training out of Envision for primary care providers, so that you can ask those questions without having your hair stand up on end when you get some answers that surprise you. I mean, teenagers have their own very active lives. Right.
And I think, you know, we are developing a multidisciplinary approach, and I think that may be the kind of person that you would want to refer, so that, you know, as we think about, you know, say you get a positive antibody test, and there's a lot more that goes into the additional screening, getting kids engaged in their healthcare maintenance, and then talking to them about adherence and deciding whether they're in a place for treatment. I think that 90% of the treatment work is that upfront stuff. And then just really partnering with them, developing a relationship with them, and then feeling that even if it's only a 12-week treatment, that's 3 months where they've got to commit to taking something every day. So you really want to, you don't want to waste that opportunity.
No, and that phone idea is so great, because they got their phones all the time anyway, right? So, any other questions out from our community of participants? Or here around the table, please chime in.
There we go.
There we go.
Blinded them with science. So please feel free to contact me if you have any questions. I have a UNM email, jfridge@celu.unm.edu. And if you have any referrals that you would like to make, you can call our appointment line 505-272-4928. And we would be very happy to see any children you worried about Hep C and complete the workup and hopefully treat.
And we do have a thank you and Dr. Fridge for all the great information from Diana Lowe.
You're welcome.
And thank you. And we do have one more request from you. If you have a couple of minutes, I put up the survey link in the chat box here. If you need that, email me. That's kwhirling@salute. And what it does is, if you have just a couple minutes, you can go to that site, fill out the survey, and it really does help us improve our delivery, our technology. If we had any issues today that we didn't know about, it's always good for us to know that. So, and all responses, of course, are anonymous, so I won't know who it is. So thanks again, and I think we are all set for today. And thanks again, and contact Michelle Widener or Carol or Maya or myself for any questions on the certificate program or anything else with AHI New Mexico. And thanks again, everybody. Have a good day.
Yes,
Thank you.
Come back next Wednesday. Thank you so much.